All right, we've got our next panel up here ready to go. And I just want to sort of provide context here. I think it's been such an interesting morning to go from talking about sort of federal, state level, some of the larger scope of the problem, the challenges, the opportunities, then to transition into really talking about Alameda County specifically and looking at the funding streams and the sort of overview of county services. And now we're going to bring it home by really talking to some of the key boots on the ground who are doing the work, some of the large nonprofits who are really making a difference in the lives of our community. And so what I'm going to ask is if each of you, and we can kind of pass the mic down, but each of you want to just take a minute to talk a little bit about who you are and what your organization does.
Right. Well, hello, everyone. I am Liz Perez-Howe, and I have the privilege and honor to be the CEO of Access Community Health. We are the federally qualified health center for the Tri-Valley, and we have been in the community for over 52 years. And we provide the full spectrum of services, medical, dental, behavioral health, for our most vulnerable community members in the area. So each year we deliver over 100,000 visits to 15,000 patients throughout the Tri-Valley. And what we are part of the safety net. And what that means is that we will see individuals that may not qualify for Medi-Cal or Medicare, which is our primary population, but are now finding themselves in a transition space and have lost their jobs and consequently have lost their health insurance. And they can come to Access and receive services and be able to maintain their health. And we saw that a great deal during the COVID pandemic. So primarily we do serve Medi-Cal, Medicare, as well as sliding fee scale patients. In addition to those services, we have a program that's called Access Bridge, and it is a mental health urgent care program. And this is a pilot initiative that we started about 4 years ago through the help of the cities and the county. So any individual throughout the Tri-Valley, regardless of their type of health insurance, can come to Access and receive services if they are in need of immediate care. So the goal of the program is to stabilize, to minimize the need for 5150s. And I'm really glad to say we serve over 1,000 Tri-Valley community members each year with close to 0 51.
Hello everyone, my name is Tamara Hunter and I'm the Chief Program Officer of Mental Health Connections. Our services are for adults with serious mental health diagnosis and are also in a journey or in recovery of substance abuse. We have 3 locations in Contra Costa County. We have a 9,700 square foot facility in Concord. We have a 77 square foot facility in Antioch and a 5,000 square foot facility in San Pablo. And what the programs offer are a community-based approach to mental health and recovery. 2 of our centers, the one in San Pablo and in Antioch, are peer support-based programs with the use of persons who are hired with lived experience that help through peer-to-peer coaching and groups and classes and art and music therapy, you name it, we kind of do it. A lot of kind of case management and housing and food insecurity, employment, education programs, and meals. We have breakfast and lunch every day, 5 days a week. Our Concord location is a clubhouse model program. And so in that program, we use, I don't know how many people here are familiar with a clubhouse program, raise your hand. And so our members there come and they are provided a structured environment that we call a work order day. And our members help run their very own program. In that they get also additional services of Dr. Insel talked about linkages. We do a great extensive amount of that every day to help individuals, again, specifically with SMI, get all of the types of supports, the gaps of service to meet the needs of our community. We too have extensive hours at the clubhouse. We're open 5 days a week, 2 evenings a week, on the weekend and on the holidays, on the actual holiday itself. So we have lots of hours of programming. And both programs are free. So a member can utilize our program at any time that we're open, and they can come as much as they like, whenever they would like.
Good morning. Ortiz, CEO of La Familia. La Familia has been around for 49 years. We were actually born in Oakland and raised in South Hayward, is what I like to say. We were born out of an organization called La Clinica in Oakland. And the founder of the behavioral health program there is the co-founder of La Familia, along with other community leaders that helped put the agency together. Now with that, we have 22 sites across this county. We provide a host of behavioral health services. I'll get into those a little bit. But altogether, we are in 5 different counties: Alameda County, Contra Costa County, also Stanislaus County, Merced, and Madera. At the core of what we do, we are a behavioral health organization. We provide both outpatient and inpatient services. We also provide school-based behavioral health services as well. And with that, bringing it back here to Tri-Valley, there are several school-based services that we provide. I know some of our staff is here. I see Lupita, Claudia, Vidal, Jennifer, our chief program officer. I don't know where she's at, but she's right there. And I do want to highlight Cultura Bienestar, Culture and Wellness. It's a program that's near and dear to our heart, and a lot of the partnerships that we have. And I have to thank Tri-Valley Nonprofit Alliance for having this space. We need more of this in Tri-Valley, so I appreciate it. And also behavioral health as well, Dr. Tribble, and just what's happened in the last few years. So I appreciate the direction we're heading in. Thank you so much. Now with that, I'll end it with this. La Familia in the Tri-Valley, through BCHIP, Behavioral Health Continuum Infrastructure Program, will be rolling out a farm. It will have 14 residential beds and 4 sobering beds as well. That's all in the mix. We don't start permits till this upcoming year, so it's about 2 years out. But I do want to let y'all know that that's happening, all due to the partnership with Behavioral Health. Supervisor Halbert has been a huge supporter of that as well. So I'll pause there and hand it off to my colleague here.
I like it. So my name is Marty Billdt, and surprise, I'm a police officer. I'm actually the sergeant of our alternate response mental health unit. Our unit consists of a sergeant, 2 officers, and 2 clinicians. We partner with Bonita House. That's why I pulled up my partner up here. And how you see us is intentional. This is how we dress. We are a non-uniform approach to those in crisis. And also, our goal is when we're not responding to crisis call, we do homeless outreach as well. I see some of our partners up here. We work with CityServe. I'll give a plug to Daniel over there. We partner with CityServe every Wednesday. We go out because our clients are all the same, and we want to provide consistency, and that's what we see, whether it's with our unhoused population or the mental health. We want to be consistent. And I'm learning as a police officer a lot about continuity of care and meet them where they're at. They're turning me into a very social worker. Yeah. So, yeah. And to be honest, this is working. Thanks, and I think we have Arkin here, council member. This has been in existence for 2 years. So it was a 2-year pilot program. They saw the need, they answered up, and they put money towards it, and we're in starting our 3rd year now. And I'll turn it over to Julie. She works with Bonita House, so we contract out with Bonita House, and if you're familiar with Bonita House, you know they're part of the CAT team, and a lot of other programs here, but I'll turn it over to Julie.
So like Marty said, my name is Julie Snipes. I'm an actual boots on the ground clinician right now. I'm an AMFT working towards full licensure. I am contracted in a crisis clinician on the ARU for Pleasanton Police Department, but my employer is Bonita House. Some of you might be familiar. Bonita House started in Alameda County as a residential treatment facility for substance use, and then expanded in 2019 and then 2020 and became the contracted CBO to partner with Falk through ACBH, under ACBH, to run the CAT program, which I have worked on, which is the county-wide crisis response. Bonita House also runs 3 other crisis response programs. One is in Berkeley, it's a non-police response. One was with Albany Police Department, which I worked in, which was partnership with police, and then here in Pleasanton, a partnership with officers as well. So I have worked in a number of crisis settings and seen how different they can all be, working towards the same goal. And I feel just very privileged to be here with a lot of the decision makers, but to also speak to the boots on the ground, frontline service provider, clinician perspective.
Thank you so much, all of you. It just gives me warm and fuzzies to think about all of the statistics and the numbers we've heard over the course of the morning, and then see it all come to life in terms of the way this actually is applied in day-to-day life and in operations as you meet with people throughout our communities. So thank you all for the work that you do. I'm going to toss out questions, and I'm just going to allow each of you to sort of pop in, and whichever one you really want to feel like you resonates for you and you want to share on. So, talking first of all about sort of the challenges that you're facing, and what are some of the themes around the problems that you see on a day-to-day basis, and some of the ways that has changed maybe over the last couple of years, or things that you're really seeing emerging either at a systems level or at an individual level within the communities and the programs that you serve.
I think we can all jump into that one pretty quickly, right? I would say workforce. It's a very unique time with all the sea change that's happening right now. And I'll say this, there's about 121,000 behavioral health clinicians here in California. Now the numbers for psychiatrists they vary. I've heard 1,500, I've heard up to 3,600, but the bottom line is whatever that number is, 45% of them are over the age of 60. So you have an aging workforce, and are we building a pipeline to bring it, up when it comes to that? The other caveat is this: when you look at both Black and Brown, and specifically when it comes to psychiatrists, only 4% of them are Latino and 3% are African American. So when we're really looking at culture competency from the top, at the leadership level, we need more of it. In addition to that, it's a very interesting time with the client population that we're dealing with. There's all this change. I mean, after Dr. Tribble and Dr. Enzel and Alex Briscoe, of course, I felt like I needed to get up here and do an interpretive dance to try to, really work through everything. But all jokes aside, you have about 10,000 people aging in Medicare every day. That's the other side of the coin. And what are we doing as a system to prepare for that? But also, what are we doing right now to really prepare some of the systems that we need for children entering the behavioral health space? So I'll get into more, but there's obviously a lot of challenges. I think the key is it's in partnership. I think there needs to be a lot more partnerships that happen, not only between us and, meaning when I say us as a service provider and the county, but also direct partnerships with SAMHSA, direct partnerships with our federally qualified health centers. But what happens is we get caught up in waiting lists, right? We need better systems to build for no-shows. Any clinic that you look at, they have about a 30% no-show rate. Let's fill them in. But yet, we have a huge waiting line as well. So I'll pause.
Anyone else want to take a stab at that one?
My answer was going to be workforce because the demand has exacerbated post-pandemic, and there is a shortage of clinicians, simply and straightforward. But I will add one more note that I'm seeing, and it's the need for system navigation. It is a complicated process, and our community members sometimes don't know where to go, where to find answers. Even, what's the first question to ask? How do I get support? And so we are finding more and more such a great need for care navigators and care coordinators and folks that will take someone's hand and walk them through this complicated process to eventually get them to the care that they need. And that is a position that is not billable. You know, it's subsidized through grants and such, but it is such an integral part of the care team. Yeah, it's just a huge piece to get people to the care that they need.
I'll put my 2 cents in for workforce as well. So our programs don't have clinicians. We are staffed with, we have line staff, and we are definitely seeing the growing need for mental health services, and the clubhouse and the peer centers are bridging those gaps. And so being able to keep staff, train staff, to help them have the supports that they need when they're experiencing situations that they've never experienced before. For example, in the spring we had a drug overdose, an OD in our facility, and we had to administer Narcan, and it was very traumatizing, to our team. And so, addressing that and then trying to, again, continue to support the team and prevent burnout.
Just from the law enforcement side, I think, to be honest, no police officers want to go to crisis calls. I mean, it's not a fun call. They're in uniform, it's already escalating. So just the idea of possibly having, and I know this is being worked on, just more crisis response teams at all hours, just to provide those community members that support, the family to support. As a law enforcement, we get a certain amount of training, but we want to turn it over to professionals. That's why this works so well in Pleasanton, and it's not always the right model, but it works for us. Expanding funding, I mean, we can all get up here and talk more and more about how we repurpose funds and that sort of things and put it towards what's needed, and that's having the professionals respond and help out and get that care that's needed.
Thank you. This morning there were a lot of conversations that came up around the pros and the cons of technology and the role that it's playing these days. And I'm wondering for each of you, how does that show up in terms of mental health service delivery, and how has it impacted, whether it's telehealth, whether it's apps or AI? How are you seeing that in your day-to-day roles?
I will say for access, the advent of telehealth and the permanency of telehealth has been an absolute game changer for our patients. They can access a mental health visit or primary care visit through the comfort of their home or their car or wherever they are, either by telephone or by a virtual Zoom. And this has really eliminated the logistical barriers, the access barriers. No longer do you have to carve out 2 or 3 hours to get to the appointment. You can just be available at your phone at 2:15 p.m. because that's what time your appointment is. And so we are seeing the ability for folks to get into care. And it makes it comfortable. It's on their turf. It's within their control, and it gives them, just kind of that ability to access care in the comfort of where they feel the most safe. So for us, that's really exciting, and we are just on the very forefront of what's to come with AI and mobile applications. I'm excited to see what we can do because I know that there is opportunity to bring power back to folks to be able to monitor their symptoms, to be able to check in with a therapist via an app or peer support. And so we're not there quite yet for mental health. We are doing some innovation within our medical space, but I'm excited to see what's to come.
Definitely pros the same as was just mentioned, but some of the barriers are, we find that in many, we call our program participants members. So many of our members don't have cell phones. They don't have access to that technology. They don't have computers at home. And so what we've been able to do is provide that at the clubhouse or at the peer centers, so our members gain experience from us, being able to learn how to use technology, and they know that they can come to, again, either center of the centers to have their appointment, their virtual appointment, and we're doing it, teaching and showing and, mentoring in that way.
For me, there's an analogy that I have, and I think I heard Lara say earlier she likes analogies, and I always say you can't make 8-track programs for an iPhone world. And with that, you also have to face the digital divide, as you were alluding to. And I think in that same respect, there's many dichotomies of sorts. Beyond any change that I've seen for HIPAA, it happened in a remarkable number during COVID. And I think a lot of us who are providers will agree the changes that we saw, how they loosened up and really worked with unrestricting, if you will, and being able to use platforms like Zoom, being able to use other platforms. I would say that we need to embrace change. I'm a basketball coach for my daughter's team. There's, a give and go layup that we always talk about, but at the same time, our team's ready for change. I know right now, and Dr. Tribble put it so eloquently, some of the changes we're going through Smart Care, it sucks. It does, right? But the caveat is, with those changes, how are these systems communicating? Are we going to all be able to communicate with Epic? Can Sutter connect with us as we all become single-payer counties? And that's really what we need to get to. And how do we embrace change when it comes to these apps? I was approached, hey, we want to start an app with you. We want to do this type of telecare, if you will. And I said, cool. For me, if we're going to do it, La Familia is going to own it. It wasn't for us to do at that point. I think for short-term care, it's something to consider. I think that we really need to consider hybrids, in person and telecommuting, or I should say telecare when we can. Because our community members that are suffering the most can benefit from some of that technology, but also can have bigger disparities as well. So it's really working through those details and those nuances of what technology can do. I'll make a quick prediction, I'll hand it over here to my colleague. I would hope that in the next 5 to 7 years, AI can have buildable codes that can auto-populate to make lives for clinicians easier. I would hope. That's not at the county level, that's at the state and at the federal level. And we need to have conversations with CMS about that. Okay? Remember CMS for many different reasons, and I'll bring it up later.
Just to speak to the role of like telehealth in care provision, for every family or client I talk to where telehealth is a great option, I run into a family or client where it does not work for them. I think that technology literacy is a huge barrier to a number of communities, immigrant communities, ESL communities, homeless populations, senior communities, where the technology literacy is a significant barrier to their care. And access. So while on the one hand, yes, it can increase access and spread the limited clinicians even further, I think it is a huge barrier for a number of people to navigate.
That was a fantastic segue into the next question I was going to ask, which was around the barriers to care. What are you, we were talking a little bit earlier around sort of the episodic nature sometimes of people seeking help only when they need it, and then that actually leaving some gaps or some lack of continuity. And what are you seeing in terms of the barriers or the challenges that prevent people from seeking help until there's a crisis situation?
So the way I'm hearing that question, I was thinking about I don't see the mom that was here earlier that was talking about her experience with SMI, but your question just made me think about a situation that we had last week with one of our members, and he was struggling a lot. And he was definitely experiencing an episode. The positive thing is that he knew he could come to our program and seek support. The plus side and the difficult side is that when we helped him get those services and we called the mobile crisis team to come because he was speaking of suicide, and our staff supported him, and the mobile crisis came, and they did take him to the hospital, but he was out the next day, and that was upsetting to the home where he lives, and so when situations aren't managed and help isn't given, and we understand those barriers, it even risks what the housing opportunity looks like, because they don't know how to manage these situations, so he could lose his housing. So fortunately, he came back to our program, and we did the process again, and they released him again. So we know that there's progress, and we want to continue to see. I'm thrilled that there's a mobile crisis team now, where we don't have to call 911. But again, for my experience with our members is that's what he agreed to go there and to get help, and then that released him. So that discourages him to, or others to want to, they're like, what is the hospital going to do and how am I going to get help? And then a good thing, again, is that we are finding this many times, at least we have a community, we have a place and a space, a support, where individuals can come and get, just be there and until they've got to get home. So I hope that all of our communities can have programs like ours. I'm glad Dr. County is here. Because although our programs are in Contra Costa, we would love to see programs like ours, Clubhouse. We know that there's peer support programs in Alameda County. We'd love to see Clubhouse also expanding into Alameda County, and that's the why, is because we have operating hours of which anybody can come in and drop in and hang out and get the support they need for many, many hours. And again, it's a free program. So we're not having to worry about what, like Dr. Enzo was saying about the pay, the pay part. We don't interface with insurance at all. It's just you can come, you can get support, you can get services, and so it's very, very needed.
Well done. You know, Alameda County has a population of about 1.7 million. When we look at the Tri-Valley, let's focus on the Tri-Valley here. What comes up for me is coordination and also how much infrastructure do we need and how much infrastructure can we prove that we need. Because when it comes to the county, they have to be Medi-Cal eligible for the most part, right? Maybe I'm wrong. Am I okay? Mostly yes. Okay. Dr. Triple will give her the mic after this, so she can correct me. But with that, we have to make sure, because like you having CAT here, having some of these other teams to deal with crisis, it's the infrastructure that we need. But again, how are we coordinating and talking to service providers and saying, how's this person going to get into this program? I don't want to put any organizations on the spot. Where are you at right now with your waiting line? When can they come in and receive treatment? When can they see a psychiatrist? When can they get back on medication? Right? When we interviewed, La Familia interviewed the police department in Livermore, not to, none with other Pleasanton, all good. One of the key things that they were concerned about is going to San Leandro area or other areas around there, and there wasn't a spot that was available. And that community member would have to come back to the Tri-Valley and try to figure out where those services could continue. Those are going to be the stopgaps that we need to figure out when it comes to crisis. So I'll pause there. So when we speak about challenges, I think that's one of the areas, coordination and a bit more infrastructure.
I'll just add one more thing. Because there is such a huge demand for mental health services, there are long wait lists. And so our Access Bridge program came about because we were getting inundated with phone calls from individuals that you could tell were escalating and needed care quickly and couldn't wait a month or 2 months to see a therapist. And so this program was designed around having therapists available that do not have panels. They don't see patients ongoing. It is simply for that moment so that we can provide care same day or next day so that the symptoms do not continue to escalate. And so I think we have to look at the need for mental health both as long-term to get folks to a place where they are stable and healthier, but also being able to respond to the immediate need.
Fabulous, thank you. And I'm curious about challenges each of your organizations are facing, and what are the challenges you as providers are facing as well, and maybe some suggested solutions for those.
As an FQHC, we rely on federal grants, Medi-Cal, as well as local and state grants. And we experience financial instability because those grants are generally not long-term. And so it's very challenging to build in infrastructure when you're not certain about future funding. And so For us, it is important to always remain grounded and try to be innovative, but recognize that this is a constant threat. And so, you know, we as FQHCs do a lot of advocacy on the local, on the state, and on the national level, so that we are just be able to have our voices heard, so that we can be able to access more longer and sustainable funding.
I'd say ditto. Ditto. We're a 17-year-old program, yay. We, as a nonprofit, we've made it this long. But yeah, that's always knocking at your door, right? And, you know, of course, it's making everybody nervous when we're hearing presentations about, which was lovely, and we appreciate, but it's scary when you're hearing about Prop 1 and all the changes that are going on, and it makes everybody feel worried. You know, how are we gonna, if our program gets cut and we're fully or part of the way, well, now where is that money going to come from? How are we going to address that? What is going to be our strategy? And funding isn't easy to get. And grants and foundations and contracts and even private fundraising, all of those things are very difficult. And so, you know, I think everybody always feels on the edge of just like, we're just trying to get through this year. We're just trying to survive. Okay, now what are we going to do next year? So.
There's so many ways to approach this because our organizations face a lot of challenges. I'll approach it this way first. I think one of the key things that happens to a lot of nonprofits is keeping good staff is difficult, keeping leadership is difficult. Planning and having succession planning is difficult. And let me get into some details. When you're an FQHC, your 330 application, where your PPS rate is your bread and butter. When you're a behavioral health organization and maybe you don't have that PPS rate, your bread and butter is the rate that you set with the county. And the key for us is, can those rates keep up with the costs that we have, not only with the management, but with the line staff. Some of us have unions. I have a union. I inherited a union, right? Which is cool. All love, nothing but love for the union. Don't want to get in trouble. But every year we have to negotiate rates to keep staff. And the key is, how can we negotiate to keep those rates where they can cover the cost? All of our organizations, at the end of the day, are expected to meet the need, but we operate at a loss. And with that, how do we make sure that we meet those needs, operate at a loss, and make magic happen, right? With that, you do have to diversify your pie. I may take a little bit of risk with some contracts to consider them, even if I know I'm going to operate at a loss, to start till that program is up and running and can bring me in enough money to cover the cost. When we say that that contract is making us money, it's covering the cost. Let's be very clear about that. So I think that's one of the key challenges. I think the other is, I think a lot of our clinicians are stressed out. I think that they are just heavily dependent on, I mean, I'm not trying to, but what happens is this, you know, and Dr. Tribble and I were at a conference about 2-3 weeks ago, and I always say that La Familia trains them and the county hires them, right? But we always bring them back, right? We find a way. For us, it's about making sure that we can really find ways to not burn out clinicians. Clinicians that are trainees, that are unlicensed, clinicians that are becoming licensed, and clinical supervisors that, because they do really good in productivity, all of a sudden you make them a manager and make that make that magic happen where you were building about 85 to 100 units, show your whole team how to do that. Does it happen most of the time? No. And we're wondering why not. The key is we need to build more clinical leadership. There's nuances to practicing those best practices to reach that. But we miss it in between because we have to meet those program goals. So I'll pause.
Very similar. We find that our ARU is a training ground, right? Because mental health, what I'm discovering, you do get burnout. You can't stay at that level, that crisis level for a long time, and they tend to move on. But that just goes along with pay, right? How do we keep them? How do we keep them in there? How do we give them, we talked living wage as a clinician or as a social worker or as a therapist to make sure they do stay. Long-term plans, I would see is we take them on as a city employee. That would be, sorry, council member, but that is how we can keep them and pay them well, give them a pension, and treat them really well so that they do stay maybe for at least 5 years till they're vested and they move on, or we give them leadership positions and we just again repurpose these positions in a different area. I just see that as a long-term challenge. I don't think the crisis teams are going to go away. I see agencies or cities bringing them on to fill in the gaps, and if we are bringing them on, we have to understand that, and what better than having experienced people whose boots on the ground has done the job are leading the new folks. Yeah. That's just from a police officer, so don't post this.
All right, well, we've talked a lot about challenges. I want to talk a little bit about hope, and I want to talk about sort of bringing all of this home. I think all of you do such fabulous work and change lives literally every day, and so I want to hear a story of hope, or something that's an actual example of a life that your program has helped, or something that you're hopeful about. And Tamara, I'm going to have you go last because we have a video to play. But if each of the rest of you have a story that you want to share to help sort of make this very personal and bring it home to everyone.
I'll be happy to start. So as I mentioned earlier, we respond out to those in mental health crisis, and we also work in the schools as well. So back in January, I didn't share this, but we brought on our school resource officers under this program because we train our school resource officers with more crisis intervention training, and what better than a familiar face when a clinician is not available than to have our school resource officer who understands the school system, works with social workers. So again, they are our second line of defense, and then our third line is obviously a uniformed patrol officer. When we do go on calls, we can transport them. So what we've recognized is a lot of times it's a financial burden to have an ambulance come, and it's just going to add more stress to the family. So when we can, we will transport to the local hospital. We will transport to whatever bed's available. It could be Kaiser Fremont, which we just did yesterday. It could be Willow Rock. It's just whatever bed's available. And to go back, I want to be positive, but to go back is, I think that's a frustrating thing. There's not always enough beds, and they have to prioritize. And so to see someone who is suffering a mental health crisis out back on the streets a few hours later can be very frustrating. But this person needs help, and you've already determined that the person needs help. So, but those are the small steps I think that have been positive. And one last thing is, I know it's only one thing, but we love it when we get a phone call and they ask, do you have a mobile crisis unit? And when they say, yes, we do, there seems to be a sense of relief. So So that's a positive that we find, and they are always so thankful when we show up like this and not in uniform. And I think it really goes a long way.
I won't share a specific instance because I am terrified of violating confidentiality, but I will share that every day when I show up to a family, an individual, a school, whatever setting we're showing up to, it is overwhelming relief that it's someone like me, or sometimes in a Hawaiian shirt, showing up with a clipboard, and my police officer looks like this and isn't in a vest and a uniform. Just the relief from the community and the gratefulness of the community that this is an option for them in their moment of need. So that gives me a lot of hope that we can see that people want this and are responding positively to it.
I was going to say, it's always my favorite when they go, "You're a cop," at the very end of the conversation. So that's good. You're doing a good job at that.
So I'm going to go off script really quickly as I speak, and I'm going to walk towards Lupe. But I'm going to tell you this. I know Liz, I think we share, I don't want to say similar background, but similar stories in the sense of, for me, I'm a product of these programs. My mom was the janitor of La Familia about 42, 43 years ago, and now I'm the CEO. I was a consumer of services for behavioral health at La Familia in the early 80s. I'm not going to bring in my family members because they're not here. But for me, I'm a product of these programs. And if it wasn't for this type of service, I wouldn't be in the situations that I'm in now. So I'm going to hand it over to Lupe to give you one specific story without any names so we don't violate any confidentiality.
Thank you, Aaron. Thank you for your trust. I'm Lupita Baratino. I think a lot of you guys know me, so. There's so many stories of hope and so many stories of wow, those wow moments that we have in La Familia. One of them that I can share right now because they're here, we have a program for promotoras, which are basically community navigators that go out to the community that have had an experience with us and want to do something for the community. And they found their self-worth. They know how much they're worth now as women. We also have men, but all women are here present today. And we have a huge, it grows every year. The promotoras, they're serving the community. Some of them serve in some of the soup kitchens that we have here in the Tri-Valley. Some of them help in other agencies, but they're always with us. That the promotoras, if they can stand up, they're here. I mean, they are one of our success stories. And I'm sure that you guys know Kika. A lot of you guys know Kika because she helps Marta, Eloisa, and Rocio. So that's one of our stories. They helped us through the pandemic, feed a lot of families, bag a lot of foods, and just take it out to the community and help when we had to do the 6 feet away, remember? Because there was a lot of our families that we served that were jobless, that were in crisis mode because they didn't have money. Everybody was March 16th, there was no money. Everybody's job was gone. And the promotoras, I wouldn't have been able to do the job that I did during the pandemic without the promotoras. And there's 4 here, but we're about, 25 when we get them all together? So thank you, Aaron.
I'll just share quickly. Recently we Access put out just a public service announcement in our local newspaper about Access Bridge, just reminding folks that it is a service, a resource available for anyone regardless of insurance. And we had a mom call in, a mom of 3, lived in the community. She was very overwhelmed, very stressed, and just thought she kind of had to muscle through, and saw the ad in the paper and decided to call. And it was a transformative experience for her. She was diagnosed with postpartum depression. Her symptoms were escalating, and she was just trying to muscle through as moms do. And we were able to link her with a psychiatrist and provide counseling, as well as link her to our group therapy. And it's especially important because it's so important to reach moms, right? Because they affect the whole family system. So do dads, but it's really important to make sure moms understand that they don't have to muscle through. And so I'm just really grateful that we were able to be there for her.
Could we play the video? Tamara's story. Oh, I think she just stepped out of the room. So.
So originally my sister became a member of it, like years and years ago, back when it was just that corner little room. And then years later, as my mental illness was getting worse, it was, I felt like, something that I might need to attend. And then after COVID, I was desperate for human contact, but I didn't feel like I fit outside of here. And I had become homeless, and I put myself in an inpatient program, and they reminded me that this place was here, and I went, that's the support group I'm on. And I remembered that, and so I came here, and when I was homeless, and I was able to get food and connect with people, and that helped me hang on. Just that there's this reality that's good, and it's not just hard. Yeah. Connection House is an incredibly integral part of my recovery that I feel like it would have been hard to do without. Learning the skills from my psychologist and then taking medications from my psychiatrist, my spirit, my faith, learning how to be strong there, and then getting my physical needs met. There's still this void of time that when you have mental illness, it can be very tricky to get out of your head, stay out of your head all the time. And so coming here, having human connection, having a safe place to just coexist with my mental illness, especially the voices that are in my head, it's constantly berating me. It allows me to practice being okay, because out there you have to just keep going and try to be okay, and it's like you're holding on, but the waves are just crashing down on you, they're just getting slammed. But then you come here, and it's like everybody welcomes you. You feel like you just got home for the day. And everybody has the same goal and the same plan in mind of just taking care of our house, taking care of our place. It's been a place where I can come back to, and there's a group of people that are just positive, and for all the little things that I do, it's a good job, or a smile, or it feels like I produce something, I'm done, I do something, I'm participating in something. Through that, I feel like it's helped me change the dialogue that's in my head of just this negative self-talk. And for something, a task I might do that's really small, when you say good job, it reminds you that those are the building blocks of how we treat ourselves, how we talk to ourselves. And so it's helped me change that dialogue of the negative self-talk in my head and make it more positive, even for just the little things. because I'm constantly making big mistakes in places. But this helps hold it together. It's like your gut, you know? Yeah. Through the work order day, I think that's really critical, that you get out of your head and off yourself and onto others and how you are with others. And it's a blessing. Yeah. I don't think I could have done it without. Ask them to please help keep this place going, because this is like our home, a place where we have family that accepts us, a place where we have purpose in our life.
So beautiful. I love watching the transition from all the statistics and everything we've been hearing all day to actually seeing the real stories and hearing the real stories from each of you. So thank you all for sharing that. It's almost time to open it up for questions. We only have a little bit of time left, but I do want to ask each of you to share maybe one thing that you're most hopeful about for your programs in the next 5 years. What's to come? And then after that, we'll open it up to take some questions from.
I'm excited to announce that next month we are expanding services in Livermore. We have been wanting to do this for quite some time and just couldn't find the right real estate. And we will be opening up a multi-service hub that will have medical, dental, and behavioral health services right in downtown Livermore, and we couldn't be more excited. And after that, we will continue to assess the needs. We're seeing more and more folks from Southern Contra Costa County, so we will continue to grow and expand as the community needs us to.
So I'm excited to announce that we hired a new Chief Executive Officer for Mental Health Connections that I will be tightly working with, and very excited about that, to have a partner. We plan to take a look at our programs, our existing programs. I forgot to mention that we, in addition to our 3 sites, we have a transportation program, of which we hire our members to drive other members to other programs and to services and to get around our great big county. And so we plan on expanding that transportation program. And then we would like to expand, so Michael and his name is Michael Dunn, will be working together, and we hope to have a clubhouse in East County and in West County and in Alameda.
For La Familia, we're rolling out 4 inpatient facilities in the next 2 years. One in Oakland, one in San Leandro, that's going to be a peer respite forensics, and in Hayward it's going to be, and I'll talk about these acronyms a little bit later when the questions come up, but a CSU and a CRT. And here in the Tri-Valley, specifically in Livermore, we're going to roll out our SUD residential facility, which I had mentioned a little bit earlier. So again, that's about 2 years out.
You know, one thing I think I'm really hopeful for is continue to bridge the relationships between nonprofits and law enforcement. You know, for so long, there lack of trust, lack of communication, and being in this unit since January, I haven't seen that. So it's been amazing, like I mentioned earlier, working with Access, working with CityServe, working with Abode, and getting people housed. And to the tune of even Halbert's office, Gloria, I believe it was here, or is here. Oh, there she is. She was over here. She moved. To where we can confidently say there's been 8 people housed this year from the streets of Pleasanton. So that's up from 3 years yesterday. So as we tied in, we know that a lot of homeless or unhoused population do have mental health illness. So the fact that our community members are getting the help that they need and we're meeting them where they're at and getting them the treatment is great. The other thing I would love to see is a weekend side team for us. So to support the officers on the weekend side. A quick funny story is, as we all are talking about workforce and not having the bodies, law enforcement, the public sector is not immune to trying to get people hiring and trying to find the right people. So when we were finally at staffing levels, we were only down to one officer, a sergeant, me, and then 2 clinicians. And when we were taking a poll, who wanted, what position should be filled first? Everyone said ARU, fill that position first because they see the value in it. So the fact that we're changing minds, we're making a difference. Very hopeful that we can just expand it. Really.
Thank you, Marty. I have a lot of hopes for the future. My hope for Mobile Crisis is the expansion in all communities, the expansion to full 24/7 coverage would be fantastic. I also am hopeful for the integration of Mobile Crisis into the continuum of care so that we can be better at coordinating care for folks, providing warm handoffs, being a piece of care and not just a one-touch, see you later. I also am hopeful for more equitable pay for clinicians. Gonna put that plug out there. Pay commensurate with experience and education that was necessary to get here. Yeah, a lot of hope for the future, and yeah, thank you.
Hello. Hi everyone, good afternoon. My name is Angelica Suarez. I work for Spectrum Community Services. We are a local Alameda County nonprofit that offers a plethora of services for our vulnerable communities. I'm here with 2 of my colleagues. I don't really have a question for the panel. I'd like to thank you for all of the invaluable information that you have shared with us. Mine is more of a comment that I'd like to make, and I'm going to have to read it if you can bear with me. I'm a horrible public speaker. I shake. I'm just horrible, so I had to write this down. If you can bear with me for just a moment. I'd like to just make a quick mention and expression of gratitude to all of the passion and dogged dedication that I see in this room today, and for all of you that are dedicating your lives to such a significant cause, as is the current state of mental health in our community, in our neighborhoods, in California, everywhere as a whole. It's just horrible. Success is possible. Overcoming is possible. Aaron, I'd like to thank you for your transparency and for exposing such a vulnerable part of your private life with us and sharing with us and showing us that you stand here before us, educating us today as the CEO of such a wonderful organization, having been yourself a recipient of these services. Thank you so much to all of you. We can do it. We can do it. Thank you.
I'm really anxious to know what all those acronyms stand for.
Well, what's happening right now is that there's a huge investment by behavioral health and also statewide, right? CSU is a crisis stabilization unit. And we're really talking about serving the highest utilizers in the county, and with that, focusing on the population that is SMI, severe mentally ill. So those are part of the facilities that we're rolling out both in Hayward and in Oakland. Here, sorry? I thought I heard a question. Here in Livermore, it's our SED residential facility, which is substance use disorder, which will have the 14 beds and 4 beds that are sobering. So those are some of the acronyms. I know I missed one or two. CRT? Okay. You know what, I'm going to give it to Dr. Trouble really quickly.
Apologize, that was not a plug for the mic. I think the ones you mentioned was crisis residential treatment. So that the difference between a CSU is that it has a shorter amount of time, and a CRT, it can be up to 14 days on average. So those are services right before a person needs to be in a locked facility. So those are resources.
But one thing, and if I may, was mentioned earlier that I said is Medi-Cal. And I want to make sure, Dr. Tribble, and I'm sorry I'm going off script here, who are committee members that don't qualify for Medi-Cal that can still get served? Because I wasn't quite right on that, so I want to make sure to keep you honest. Yeah. That's why I want to give you the mic.
I will be right back. Thank you. So we can also serve, this is a political, I want to acknowledge that, but if you are uninsured, undocumented, if you are unable to be connected with your health insurance, you don't know what that is, if you're an adult caregiver with a person who has insurance but you don't, and oftentimes, as you know, there are limits to that. We'll wrap around and we can serve you. We also we try to bill our private insurance partners. If they pay us back, we receive it. If they don't, they don't. But if people also have Medi-Cal or Medicare, we can also bill and receive services for that. And when I say we, the county.
Thank you. Hey, my name is Daniel. I'm from CityServe. I run our outreach team. And I kind of wanted to pose a question for you leaders to speak to some of the folks in the room who can move the needle. I think a part of the sentiment here in this part of the conversation today is the practical application. And so from an outreach perspective and someone who's boots on the ground, working with the most vulnerable, the most distrusting, at times the most deteriorated folks, we can build a foundation of trust. That's really the job of outreach, is to visit the folks who aren't going to make it into the office, aren't going to make it into your buildings, but build a level of trust. And so from that position of trust, I can say, okay, let's work on your housing navigation. Let's work on your medical needs. Let's work on your behavioral health needs. Even let's work on your substance abuse needs, right? And those are long hours and conversations, and sometimes just fun, right? Because we need that foundation of trust. I think what I hear is an overarching need for staffing and funding. And from a practical level, what that means for someone who's in the field is we can build a foundation of trust, but then when it comes to referral and this big step for an unhoused individual or someone at risk of homelessness or a child struggling, if they aren't met with the same level of care that they've learned about, and that's at no fault of the organization, right? Because I can stand and say, I understand those needs, I understand those challenges, and there's executives and leaders here who want the very best and they want progress, but they're shorthanded. And so we have a rare moment where you as leaders can speak to county and you can speak to supervisor office right now and be able to say, this is what we need desperately, right? And then that, in turn, helps us as outreach workers or even the care coordinators are here, or the folks who work directly one-on-one with individuals to really provide great care. And be able to say, yeah, you're gonna be able to go to X location and get exactly what you need. And good job, because you took a huge step in trusting this system. So that's my post question is, what do you need, specifically to county and supervisors that are here?
Well, speaking from what services that we provide at Mental Health Connections, again, we've talked about the need for funding. Any of us sitting in the room and the organizations we work with, we shouldn't have to worry about where our next funding is going to come from, and cuts. Rates and aren't going up, and COLAs don't cover the prices when you're talking about having good staff and keeping staff and turnover and whatnot. Keeping up, it's not the pay rates, and again, the COLAs aren't covering the cost of increased prices of staffing and your cost of programming and your building and your rent and whatever the circumstances might be. So definitely funding is always really, really important. And in order to grow programs, you need it. And from my perspective, I think, I'm working together with a coalition in California to grow clubhouses, which is why I'm talking about so much about that. I helped get clubhouses going in California, and actually I'm on the accrediting body of Clubhouse International, and I help clubhouses grow and to be the best they can be around the world, because we are an international model. And I think as much as having the peer centers, we heard today that peer support is something that is billable now, but Clubhouse is actually, we hear, is getting into the language as well in California to be billable. Our types of program, community-based organizations should be in every community. We should have a wellness center and we should have a clubhouse. And those organizations are a super important part of the continuum of care, and the gaps that we're able to fill when you aren't able to get services. We provide food, thanks to TVNPA. We got a grant and we're able to just buy groceries for our members, cover transportation. I can pay rent through programs that we have. If someone is unhoused, I can put them in a hotel until we can find them a place to live and pay their rent. We can pay PG&E. We do so many things within our walls, and we make a lot happen with the little bit of money that we get, and all of those things are important. We do have mobile. We go out mobily and we meet people where they are at, and we go visit. If they're not comfortable with coming into our program, we will go there. And we will help them with those applications. We'll help them with anything that they have and need. And so again, all these programs are important, and we need them all. There's so much need. There's so much need out there. So we, somehow we've got, you're right, we can do it, but it does take money to be able.
Okay, last comment. I do want to say the coalition models work really well. And so I'm grateful to the county for putting forth these grants that have allowed where TVNPA anchors us and to be able to work together. Because when you put forward 5 different organizations together to coordinate services, that is very powerful. Because in that table, someone holds the trust of that community member, and we can seamlessly then pass on the referral.
Thank you to all of these amazing organizations doing fabulous work in our community, and thank you again to the Tri-Valley Nonprofit Alliance as well as to the Tri-Valley Anti-Poverty Collaborative for making space for this amazing conversation today. So let's give everybody a round of applause.
Thank you so much. And to be clear, because it might not be entirely clear, the Tri-Valley Anti-Poverty Collaborative is a program of Tri-Valley Nonprofit Alliance. So this is one of the programs that we have. That was a fantastic program. Again, I want to thank Supervisors Hubbard and Miley for sponsoring it. Supervisor McMiley is here. We really appreciate you showing up and showing your support in these conversations. It's really important. I'd like to thank Dr. Kara Tribble for her talk this morning and this wonderful. Please help me say one more time.